Hello, everybody. Welcome back to another episode of the Find Your Model Health Show. I hope everyone's really well this morning. I couldn't be more excited to have my friend and colleague, Paul Robinson, on the show this morning. I've told many of you that Paul is coming on, so hopefully we don't let you all down with the content we bring you today, but I think it's going to be pretty good. So, Paul is a British author and thyroid patient advocate, and Paul is going to share some of his own experience with thyroid with us. But because of his own struggles, it caused him to enter the world of thyroid. That wasn't his original practice. And from there, he's been able to help patients recover from hypothyroidism as fast as possible, which I know we all want. But his illness also encouraged him to delve deep into the research and then not only help people, but put it into his books. He has three books: Recovering with T3, the CT3M, say that real fast, the CT3M Handbook, and the Thyroid Patient's Manual, which I love. And that was the first one I purchased of yours, Paul. But Paul is just an absolute wealth of knowledge when it comes to thyroid and hypothyroidism and the treatment and pretty much everything that frustrates us around thyroid nowadays, right, Paul?
Well, yeah, first of all, thank you for having me on your show. It's nice to be here this morning. Yeah, I mean, the books cover, when I started, the first thing I wrote was Recovering with T3 because I only got well with using T3, liothyronine. So I had to write something about that. In fact, my own doctor encouraged me to write something about it.
Yeah.
But, the rest of my work, including the Thyroid Patient's Manual, it covers the whole gamut of thyroid treatment and thyroid issues and everything associated with it, really, including all the nutrients and things that need to be in place and cortisol. So, yeah, I've touched pretty much all of that area over the years.
The books are great. And that one, the Thyroid Patient Manual, like that was the first one I got here. And that one, it's so in depth. It reads like a lab manuscript. It just covers everything. It's like if you don't find your answers in here, nobody can help you. It's so good. You must have spent ages doing all the research.
Wow. Well, that's an interesting question. I wasn't sure if I was going to answer it completely honestly, but I actually wrote the book in 3 months,
Yeah.
believe it or not, out of my head.
Yeah.
I didn't have any notes. I basically bought two huge whiteboards, spent 10 days making the notes on the whiteboards, and spent 3 months writing the book, and then 6 months editing it. And the only reason I did it um, was because I'd spent the previous year basically with traumatic stress syndrome. Because one of the consequences of my own hypothyroidism was that I lost my career and
Mhm.
then I lost my marriage. And as a net result of all of that together, I lost contact with my two children. And that had happened the previous year. And I haven't spoken to them since then, which is 7 years ago.
Oh my gosh.
Um, so I had PTSD, really bad PTSD, and I was in a right mess. Had nervous shakes and things like that all the time. I was in a bad way. I tried antidepressants, but that didn't work. So at the end of it, I said, it's gone on long enough. It's gone on a year. I'm going to do something. I had this idea for a book in my head, which was going to be called "How to Escape from the Thyroid Maze," and
Mhm.
how to start from square one, from where you are, what you need to do, what you need to test, what steps you need to take. And eventually that became the Thyroid Patient's Manual,
Mhm.
which is it's more of a step-by-step approach to navigating your way out of hypothyroidism.
Yeah.
So yeah, it was written incredibly quickly,
Yeah.
and to
But
write the
that's
whole
not too long.
3 months is really fast to write a book.
Well,
And
in our context, I think when you already have everything in your head, it's just a case of putting it all on paper and filling in the details.
yeah, yeah. But having said that, the first book took me about 18 months to write. Recovering with T3 was a long, long, long effort. But that one was fast. But it was done for a reason. Mostly, it made me sane again.
Yeah.
It got me out of it. And that was all to do with the damage that hypothyroidism can cause when it's not treated properly.
Yeah, and that is perfect segue into the first question I really had for you is not so much anymore, but I think in your older conversations, you used to be very passionate and even emotional when you would speak about the disservice that people are experiencing with their low thyroid treatment. And um, I wanted to touch on that. Why do you think? One, you got so emotional. Obviously, there's a connection to your own story, and I had mentioned my anger earlier to you over the whole lot. Well, this disservice, where is that stemming from? What do you think is going on here?
Wow. I think that the understanding of how the condition should be treated is so poor amongst doctors and even amongst endocrinologists. They're so dogmatic about the way they go about it that they inevitably leave a, a reasonably large proportion of people still sick. You know, they do. They just leave them sick, whether it's because they never want TSH to get low, for instance. That's one reason. Or whether it's that they don't really want to prescribe T3, which often they don't. Um, they just leave people sick. And so what happens is someone just goes round and round and round the circles with them. They go back to the doctors every so often, go back to the endo every so often, and they make an adjustment of a levothyroxine dosage, either up or down or whatever. And this can go on for years. And that the damage, the collateral damage that happens to a person's life and all those around them during that process is huge. Um, why does it persist? It persists because of the dogma associated with current treatment methods amongst the medical profession. They insist on having labs in range. They insist on TSH never being suppressed. They don't want to prescribe T3, and if they prescribe it, they prescribe it in tiny, tiny amounts, which doesn't often doesn't do anything. And when they do prescribe it in more amounts, if the person doesn't respond to it because the T4 dosage hasn't been lowered or something like that, then they say, oh, it's not working for you. Whereas in actual fact, they just haven't explored the balance correctly. So there are many reasons for it. Um, and it comes down to, I think, education in many ways. The way it's been taught to doctors and endocrinologists, the way it's been taught how they're supposed to behave, it's just wrong. They've just got the whole thing wrong. And yes, it works for a certain number of people, the ones that were always going to respond to levothyroxine well, and a lot of people do. A lot of people are fine on T4 medication. But there's a proportion of people, and a huge number, I mean, maybe not a large percentage, but a huge number of people, but it just doesn't work right. And yeah, the whole medical professions it's got this within it. There's almost no doctor, very few doctors know how to deal with it properly. Let's put it that way.
I feel in Canada, and I can only speak for here right now, it's they don't want to know. Like we were saying, they don't listen to the patients. You're in and out, and they don't want to know the fine details. They just want to prescribe you and move on to the next patient. And even getting tested here is very difficult. Like it's a constant uphill battle for people, and it's so discouraging for a lot of people. They think there's no hope. This is the rest of my life.
Yeah. And what's more amazing is that the treatments they have these days for cancer, and they're getting more and more complex and more sophisticated, that seems to be making progress. But thyroid treatment basically has gone backwards. It's worse now. It's worse now than when I was first diagnosed. At least then, when I realized what I
Yeah.
needed a trial of T3. I could go to my GP and say, this is what I think I need to do. And I would have a positive response.
Yeah.
Now it have a door slammed in your face.
No,
You know,
sorry, we're not doing that. Yeah.
exactly.
Yeah. It makes you wonder though, because as Broda Barnes has mentioned in his wonderful book, all the different health issues that are correlated to hypothyroidism. Is it a bigger money factory to not put people on thyroid and have them use all the other medications? Because the answers are just like you said with the cancer. We already have a lot of the answers, like me and you and a lot of other people know how to treat hypothyroidism. We know the answers. It's
Mhm.
just not being utilized in conventional medicine.
Yeah, I don't think the majority of doctors are that cynical. I think the majority of doctors just are taught that this is what you do and this is how you treat it, and they don't know any better.
Mhm.
Now, whether the I I don't know. I don't necessarily ascribe to the big pharma theory that, they just want to sell levothyroxine. They want to keep people sick. I don't know. I'm
Yeah.
not necessarily as cynical about that as I maybe used to be. Um, but I think a lot of it is just not lack of education, and also that the medical profession seems to be so slow to move on this, that there's so much inertia in it compared to, you know, treatment of heart, cardiovascular disease and the treatment of cancer again. They're moving fast with that. But this area hasn't moved at all in
Yeah.
30 or 40 years. It just stagnated. They're still saying the same things. You have to get your TSH in range. And if you get tested for TSH or FT4 and FT4, you're lucky. And you
Mhm.
have to beg to get tested for F3 T3 and forget reverse T3. You're
Yeah.
never going to get tested unless you go to a private lab and just pay for it with your own money.
This is it. Most people are paying out of their own pocket now because they're not getting the help anywhere.
But
Um,
sometimes it's better to do that because otherwise you're going to be left sick for another year, another 2 years, another 3 years. And that's just not good. Your whole life gets whittled away.
I think that's it. A lot of people I speak to now have accepted that, look, if I want to get better or make any progress, I'm going to have to pay out my own pocket. It's unfortunate, but there's no other alternative.
Yeah. And I think in many cases that's true. And I think it's better to do it and then find out, work with someone who can help you determine what you need to do, and then just get to a solution as fast as possible. I really believe this disease has to be fixed quickly, because if you don't fix it quickly, it can cause other health issues down the line, cardiovascular problems and whatnot. And you just need to get it dealt with quick before any other damage occurs, by be it personal damage in your own life or be it with other health issues. So doing it, just getting on with it and taking
Yeah.
responsibility yourself is what you need to do.
Yeah, like with you, it can destroy your life and you don't even realize it because it's messing with your mental health, it's messing with your physical health. It takes over.
Yeah.
So you mentioned TSH there, and I want to talk about this because really it's the only test that's done here to test your thyroid, which just I have to laugh. I'm like, come on, really? Like it's a pituitary hormone. It's not going to give us a great idea of what's happening. Um, and as Keith has taught me over the last few months and a few others, that even if they do test TSH, most doctors are not aware that, okay, then we should be looking at the red blood cells, the ferritin, the cholesterol. But most doctors are not. They're just like, yeah, everything's normal. Bye. See you in 6 months or
Yeah.
12 months.
Yeah.
So, what's the problem with looking at TSH alone? Because the average person doesn't know the other stuff. So they go get tested. My doctor said everything's normal. It looks normal. Here in Canada, the range usually varies from, I don't know, I've seen 1 to 7, which is
Mhm.
insane. So I
Yeah.
think the average range is 1 to 5 on TSH.
Yeah. I have loads of problems with it. Loads. Because, well, I mean, one of the big ones is that doctors know that they can test a full blood count, and they can look at red blood cell count, and they can look at various things, and they can see things that are wrong. Um, but they think TSH is going to be a black and white simple measure, that the pituitary that's producing that TSH signal is always going to be completely perfect. It is never, ever, ever going to fail.
Mm.
It always produce an absolutely accurate image of how much thyroid hormone that person has. And as we know, virtually everything in the human body can fail.
Yeah.
If it doesn't fail, it can deteriorate. I'm wearing these things, okay? If I go out to a noisy place, I put hearing aids in. They don't work so hot anymore, okay? Um, Everything can go wrong. You can get heart problems, you can get liver problems, everything. But they believe that pituitary gland is always perfect. Now, they should be aware that you can have a condition called central hypothyroidism, where the pituitary actually doesn't produce adequate hormones. But you do get maladjusted pituitaries that don't produce a good signal in terms of it could be TSH, it could be ACTH for cortisol, it could be anything. You can't trust it. Measuring it alone makes no sense whatsoever.
Yeah.
It could have a low reading even. It could have a reading of one, quite low in the range, but the person could still have low thyroid hormones.
Hmm.
So looking at it alone is just absolutely borders on mental. It's stupid. It's completely stupid
Yeah.
to do that. I mean, the other thing about it is the pituitary gland is the it always has the highest concentration of free T3 out of all the cells in the body. I mean, they've done that with experiments. And the pituitary is superb at converting T4 to T3. It uses both enzymes, D1 and D2. It's great at converting it. So if it's got a meager amount of FT4, it can make a great job of producing FT3. And of course, then it uses the FT3 that it sees inside itself to decide what TSH level should be.
Yeah.
So the person could feel deeply hypothyroid, but the pituitary could be sitting there thinking, well, I'm okay.
Yeah.
I'll put this reasonable TSH out. You just can't trust it. It's not enough to look at on its own.
Yeah.
It just under any way, shape, or form. So they
Yeah.
should never use TSH on its own. If someone's got hypothyroid symptoms and they've got, maybe high cholesterol as well, which they could look at, for instance,
But they don't. Yeah.
but they don't. But if they've got hypothyroid symptoms, they have to test the other hormones, and that doesn't just mean testing free T4.
Yeah. And that's it. The pituitary is like, I'm fine, I'm taking care of myself. But just because the T3 is there, there's none then systemic, and you have all these horrible symptoms. Um,
Mhm.
TSH is just so unreliable. It's almost pointless just looking at TSH, which is what the majority of doctors are doing, and then patients are not getting the help that they need. So that brings us to the lab ranges, and lab ranges vary from not only practitioner to practitioner, but lab to lab. But you've
Mhm.
also spoken about from individual to individual that the ranges, just because you look like you're in the range, doesn't mean like that's optimal for you either.
No, being in range doesn't tell you if it's optimal. There is research that's been done that says that you need to be in the right one-third of the range um, for you personally. Um, so, you could have a free T3. Say you're free, I'm not sure what your lab range for free T3 is, but over here it would be something like 3.3 to 6.6,
Mhm.
right? So you could have a result of 4 or 4.5, but you could be low for you personally on free T3. You might need to be 5, 5.5, even 6 for you to be okay. And I
Yeah.
know people need to be right at the top of the range, really right at the top of the range
Yeah.
for them to be okay.
I think that's a
Or
lot
even
of people
a
because, yeah, I think that's a lot of people because not everyone, but what I see is when people are on T3 and they still have all their symptoms and they're not experiencing any sort of improvement or progress, I am saying, well, you need more T3, but the doctor, of course, is reluctant to increase it. And then the patient is apprehensive because the doctor has told them, oh, no, you shouldn't because you'll have a stroke or whatever. And it's
yeah.
this constant back and forth all the time.
Yeah, absolutely. Yeah. I mean, I don't take any T4 medication. You know that from my story. So I just take T3. Um, and my range, I said before, my range is 3.3 to 6.6. If I tested my free T3 within 12 hours of taking any, my result would be about 9 or 10, maybe way over the top of the range. I wouldn't even be close to the top of the range, but I'm not hypothyroid. I've just got the amount that my cells need.
Yeah.
I don't really care about my blood test result particularly. I've got what my cells need to keep me normal. Okay.
Yeah, so
So
to find that individual range, you're recommending look at your symptoms. The labs are almost
yeah,
relevant.
I think for the majority of people that are on a T4, T3 combination, when they're on, moderate amounts of T3, they can use the ranges, but they need to maybe expect that they might need to be higher up the range. I mean, I'm an extreme case where I'm just on T3 and I might need to not take the range into too much account,
Yeah.
but most people can take the range into account and they may well need to be much higher up the range. And often to achieve that, they might have to reduce their T4 medication and add T3. Otherwise, they'll end up producing lots and lots and lots of reverse T3, which won't help them at all.
I did want to discuss the reverse T3, but I think, and you correct me if I'm wrong, in your case, you have so much experience and you know yourself so well in your body that you know this range and this dose of T3 works for me. I feel good. I'm not feeling any negative effects. So you're quite in tune with your body too. Do
Yeah.
you think as well? I'm pretty sure I know your answer, but the older you get, the more you're going to need to increase the thyroid because everything starts functioning a little bit lower.
I haven't increased mine much for about 10 years. So I'm 66 next month. So for about the last 10 years, I've been on 60 micrograms of T3, 60, which isn't a lot. I know a lot of people who are on a lot more than that. It's a fairly modest dose. It's been stable for 10 years. I haven't had to change it. In fact, sometimes I've had some other illness, like a virus or something like that, and I felt, oh, I might need to change it. But every time I've done that, it's been a mistake. So I'm pretty stable. And whether or not it'll change as I get even older, I don't know. But in my case, I know my cortisol is just about spot on perfect. It's ideal. So
Yeah.
that helped,
Yeah,
that
for sure.
those two are partners together, cortisol and T3.
So how are you dosing the 60 micrograms? Are you taking it all in the morning or are you splitting the dose across the day?
I take 3 doses. I take one in the middle of the night, about 3 a.m., which is
Okay.
my recovering with T3 book. Part of that protocol called the circadian T3 method, and that helps keeps my cortisol good. And then I take one about 11 o'clock, 20 micrograms again, and then one about 3 o'clock in the afternoon. So I
And
take
are you
one.
taking them on an empty, well, obviously the 3 a.m. one's empty stomach, but the other two, are you taking them with meals?
I'm not bothered really when I take them. I've never noticed any difference. I know that some people think it's better if you take it without food. It tends to hit most times when I take it w without food, but in the occasions I have taken it with food, it hasn't making any difference at all. I
Yeah.
think the T3 absorbs a lot faster than the T4 medication does.
Yeah. Oh, yeah, for sure. There are a lot of practitioners that, and conventional doctors, of course, tell people to take it on an empty stomach first thing in the morning. And then there's other practitioners that are adamant you take your T3 with food because it kind of piggybacks on the absorption of the other nutrients. I generally like either way, I don't think it's a big deal as long as you're getting T3. That's the big deal with myself and my clients because I know my clients' lifestyle and they're rushing out the door to work or kids' school or whatever, but I also know they've a lot of stress, they've a lot of digestive issues. So my general recommendation, I know if I don't get them to take it in the morning, they're probably going to forget. So it has to be done in the morning. But also because a lot of the women, especially I work with, they already have damage to the digestive system
Yeah.
that I'm encouraging them to have either some warm water and lemon juice or tea or something to stimulate the
Mhm.
digestive system so that at least if they are taking it on an empty stomach, we're going to get some sort of absorption there. And that seems to be pretty doable for my clients. Again, if they don't take it in the morning, like all the other supplements, they'll forget as the day goes on.
So do the majority of them are they also on T4 with it?
Uh, no, here's why. Because it's a big challenge in Canada to get treatment, like a huge challenge. I have a lot of clients, and out of all of my clients, I think five of them have gotten T3 off their doctors. The others have had to resort to getting it themselves, which is one of my questions that we can go into if you want right now. Like if you're not getting it off your doctor, what's the alternative? What do you do?
Well, before we come to that, which is obviously we have to be a bit delicate about how we answer it, but before we get to that, the reason I asked you the question is because when I first got T3, the doctor that gave it to me said, "Okay, we think we both agree, you and I'd reached that conclusion as well, that I need to try T3 on its own." So he said, "Here it is," and he said to me, "You'll have to work out how to use it." Because I had no idea. And in those days, there was no internet, there were no books on it, there was nothing.
Yeah.
So I had this medication, which I was desperate to get because I thought it was going to answer me, but I had no clue. So I had to work it out. And over the next 3 years, when I was doing various experiments, I tried lots of doses, lots of ways of taking it. And I tried a single dose in the morning. And I tried it anywhere from 40 micrograms right up to 150 micrograms, believe it or not. That was a massive experimental kit at the time.
Yeah.
And to whatever dose I did, I could get a dose that would work fine for a few hours, but nothing would work for 24 hours, which is why I end up multi-dosing.
Yeah.
And I know some people can do it one dose a day, but a lot of people can't. And that's kind of why I was wondering about your clients that take it once a day, whether they take it with T4 meds, which would obviously help them go through 24 hours much more easily. So my experience with it is it's better with multi doses.
Yeah, and I do have clients that do multi-dosage. One comes to mind that I think she'd be amazing if she was consistent, but she's not consistent with it, which comes back to I don't know if it's Canadian lifestyle or what, just people are so busy over here, they forget. So in the morning, I mean, I do great with one dose in the morning, like great, but I'm also using other complementary therapies. I'm using aspirin as well. I'm using progesterone. So there could probably be something to be said there that later on when I use progesterone or aspirin, I'm stimulating the thyroid. So that's why I don't need two doses as well. So I don't know, but with let's go into it with accessing thyroid. Like, what do you do if you can't get a prescription? What do you do? Like,
First port of call is you go on more than one thyroid forum and ask the question to patients there. I always say if someone's asking me what do they do about getting T3 and their GP or endo won't prescribe it, I say go on as many thyroid forums as you can and ask patients. I mean, I'm telling where you live and say, look, do you know of anyone privately or anywhere that will prescribe it, or do you know of any other sources of T3? And that's what I tell them to do. What I try, I know there are places that you can get T3 on the internet, and some places that are very, very safe to sources of T3. I try not to get involved with that directly with patients if I can help it. When someone's particularly desperate and they've tried everything else, yes, I can help them out a little bit. But it can be got. There are always ways and means of getting things, be it T3 or be it other medication. There are
Mhm.
ways and means of doing it. And what I would say is if you're working with doctors or endocrinologists that are keeping you sick, going to making your life a misery because you can't get well, then you need to take responsibility and you need to find a solution. You absolutely need to find a solution. Don't be trapped in ill health by them. It's your body. You're entitled to feel well if it can be made well.
Mhm.
So
And I'm just going to add, don't be worried about upsetting your doctor because you're taking your own action. Like people don't want to upset their doctor. Like this is your life. You've got one chance at this.
yeah,
So
absolutely.
there is other ways at getting it. Human beings are quite resourceful. Like in Mexico, which is like Mexico is to Canada what Spain is to Ireland and England. Like
Right.
that's where they go on vacation. In Mexico, you walk in, you get it over the counter. So a lot of people will go on vacation to Mexico and they'll bring back T3.
Yeah.
I have some clients in Thailand. Same thing, no prescription. You walk into the pharmacy,
Mhm.
tell them what you need. There you go. Even progesterone, testosterone, everything.
Same in
Really, we should have access to this stuff. We're entitled to have access to this stuff, but we don't. So, as the saying goes, where there's a will, there's a way.
Yeah, I agree. It's the same with, I mean, same with something more benign like B12. In Germany, you can get it over the counter in a pharmacist, for goodness sake. They treat it as a just another supplement. Whereas here, in the UK, if you're low on B12, you have to plead and plead and plead to get a B12 injection. If you get one, you're lucky. So, but there are ways and means of getting that as well. So,
That's gonna blow my listeners' minds because here you just get B12 in your grocery store. Like I can get mountains of B12 if I
I'm
want.
talking about ampoules for injections.
Yeah, so we can get IV as well.
Really? Okay, that's as easy
Um,
as that, is it, in Canada? Okay.
yeah, and I was speaking to my little brother who's back in Dublin a while back, and we were speaking about melatonin because he was having sleep issues. And
Yeah.
he was saying, and God, I haven't lived in Dublin in 11 years, but he was saying, no, melatonin is prescription only in Ireland. Which is crazy because, like, in Ireland, it's like a substance, and here I can get it in Walmart if I wanted to.
Yeah.
It's
Yeah.
just crazy how it varies from place to place. And even my sister was telling me she was having issues finding aspirin in Dublin. And it's mind blowing. We should
Yeah.
have access to all these therapeutics.
I agree. I agree. Well, with B12, going back to the B12 example, you can order it from Amazon in Germany, basically, even to the UK. So we can
Yeah.
get it. So it's very easy to do. T3 is not quite as simple as that, but there are always ways and means.
There's a lot of, I mean, I can understand why people are apprehensive to order from third parties or whatever, but sometimes you do just have to bite the bullet, take the risk, and become your own guinea pig like you were.
Yeah. Yeah. With a reasonable amount of knowledge behind you. I mean, you, I think you need to know
Yeah.
enough before you do that, for
Or at
sure.
least have someone to help you or one of your books or something. Don't just start popping a load of pills and hope for the best.
Thanks. Yes.
So let's go back to the different types of treatments. So we've mentioned the levothyroxine, which we call Synthroid here, but there's multiple different names. So T4, we've mentioned that would be the most commonly prescribed treatment for most people for thyroid.
Yeah.
But in a lot of cases, it doesn't work. And I'm specifically referring to my clientele because my clients have a lot of systemic inflammation. There's a lot of stress. I could argue about the toxic exposure here in Canada. Food is a bit different than it is in Europe. You know, the regulations are different here. We're allowed to use a lot more chemicals and pesticides than a lot of Europe is. So I think that is playing a big part in the efficacy of T4 and the conversion of people.
Yeah, could do. I don't know much about that sort of side of things, the pesticides, but it could well do. But there are so many reasons why T4 doesn't convert. I mean, one of the biggest ones is the fact that someone's got a thyroid damage in the first place. The thyroid gland's the single most important converter of T4 to T3 in the body. And if you've lost a reasonable amount of thyroid tissue, functional thyroid tissue through Hashimoto's or whatever condition, then you've lost conversion ability and that's not coming back. You're not going to go into a shop and buy the extra bits you need. You can't. You've just not as good at converting anymore. And also people have gene defects as well, inherited gene defects um, that can impact conversion. And once that starts occurring, that's kind of switched on and it's hard to switch off as well. But yeah, all sorts of issues can cause conversion issues, and not all of them are that easy to fix. And in the meantime, even if you are working to try and fix the ones that are fixable, you really need the extra T3 or less T4 and the extra T3 in order to give yourself the right amount of thyroid hormone.
Mhm. I
Yeah.
also see fatty liver is a big problem here, and that's going to impair conversion as well, or any sort of liver damage or stagnation. And it just, according to the research, the amount of people experiencing fatty liver and liver steatosis, it just keeps growing and growing and growing. Like it's a big problem that we have.
Mm.
I
So,
have a client who had a complete thyroidectomy and put on Synthroid for the rest of her life. And I believe 250 micrograms is what she's on. But she's still having all these symptoms. And she's not making progress in like her physique goals with weightlifting and whatnot. And had encouraged her to go back to her doctor to get T3. I'm like, you're not converting that Synthroid. It's very clear you're not. So she started T3 maybe 3 or 4 weeks ago, along with the Synthroid. Doesn't seem to be making progress yet. I believe it's 25 micrograms every morning is what she's taking. So still pretty low. She has no thyroid.
yeah.
Um,
I almost always suggest that people drop their Synthroid a lot, a massive amount when adding T3 in, because if you don't, all you're going to do is push more and more of the free T4 into reverse, and the process of producing reverse T3 tends to block the T3 itself. So it's like, if you add T3 to the T4, you think you're going to get extra free T3, but in actual fact, you could test it a month later, and your free T3 could be the same as it was to start with, even though you've added 25 micrograms. Could even be lower because that free T4 is not converting to T3 as well anymore. So often you really have to cut it a lot, but 25 micrograms for someone like that it's not an awful lot. I mean,
no, it's
starting
very low.
starting dose is okay.
Yeah.
Yeah,
Well,
but
I think because the last time I looked at her TSH, it was zero point 0.2, and I think that's what the doctor's going off. So pretty much perfect TSH, but still all the symptoms.
yeah,
So anyway, luckily enough, he did prescribe the T3. So that was a start for sure.
yeah. And also,
Hopefully this conversation helps then maybe encourage some more action.
yeah. And also as TSH comes down, very often conversion comes down as well. So you tend to have worse conversion from T4 to T3 as your TSH gets lower. So
Why
adding
is
T3,
that?
why is that? Because it's used in the cells. It's used in the cells to affect the regulation of D1 and D2 deodenase enzymes.
Mhm,
So the higher TSH will usually give you a higher number of D1 and D2s
mhm,
that convert T4 to T3, and a lower TSH will get you a lower number of D1 and D2s.
mhm,
Also, a higher TSH will give you a lower D3 enzyme, which converts free T4 to reverse, and a lower TSH will give you higher D3 enzyme. So it affects conversion. So I have no problem at all with low TSH. I absolutely don't. It's often needed, but
mhm.
often when you add T3 to T4 treatment, you're actually making your conversion worse because the TSH might even be more suppressed. You really need to cut that T4 dosage down because it's the T4 that's causing the problem. It's just not converting.
Yeah.
So getting far less of that. I often get people I work with to cut it by 50% straight off the bat as soon as we add T3 in.
Mhm.
And they're really like, oh, shouldn't I just add the T3 and see how it goes? No, it's not going to work.
Do you notice
No, it,
then they will see an improvement? So they're on, let's say, 200 micrograms of T4 and 25 T3. They're seeing no improvements or changes, core temperature doesn't increase, and then you cut that T4 in half. Do they start seeing then incremental changes?
often they don't see that much difference, but it doesn't get worse, but it gives you the scope to increase the T3. Sometimes they can feel better.
Yeah.
Really depends on the person. It's just a matter of you never know quite what numbers you need to end up with. As you know, you never know what your T4 dosage and what your T3 dosage needs to be. But usually I don't just vary the T3, I vary the T4 as well. Usually that T4 is coming down as the T3 is coming up. And then you find a balance point where you see free T3 starting to come up on lab tests, and the person is starting to get warmer, better body temperature, the symptoms start to go away. I've
Mhm.
had a client recently I'm working with, and she's feeling pretty good now. She started with 125 micrograms of T4, and now she's gone to 50. She started with 10 micrograms of T3, and we're on about 30 or 40. So it's a different, completely different ratio. We're talking about almost the same amount of T4 and T3 here, as opposed to being on 125 micrograms for the last 5 years and feeling sick, really
Yeah.
sick. So,
I think
yeah.
it's important for us to highlight that there is a lot of trial and error. Just because you don't feel changes immediately doesn't mean that it's not working and you should quit. And also, there are some people who won't feel improvements immediately. Some people, it might be a month or two before that T3 really starts to help them turn a corner.
Yeah, it can be that case. Yeah, I think lab tests do have a role though. When you need to look at what free T3 is doing, reverse is doing if you can, and measure assessing body temperature, heart rate, BP, keeping a track on what's happening. So because once you start seeing improvement in the vital signs, in the temperature, etc., you really know you're on the right track. And
Yeah.
once you know you're on the right track, you know the changes you're making are going in the right direction.
Taking
Yeah.
core temperature is something I do a lot with my clients every morning because it's simple, it's doable, it's affordable, and it's a pretty good indication of if things are going up or down. Like if you're feeling cold all the time, your thyroid is not optimal, your metabolism is not keeping you warm. And
Yeah.
then I will use pulse, but again, this is not a cop out, as we would say in Ireland and England, but people are like, I'm so busy, I forget to check. So the pulse thing, a little bit harder, but at the very least, I want people taking their core temperature. And not only for thyroid, I'll also use it for ovulation and stuff as well.
Yeah, I think your clients might not like the way I work, to be honest, because I tend to ask people when they've got a day off, they're not busy at work, they've got a day off, try and have a day. If they're on T3, and particularly if they're taking multi doses, I like to know what the temperature, the core temperature is, the BP and the heart rate before they take their T3 doses, and what they're like 2 to 3 hours afterwards.
Yeah.
I want to see that temperature start to move.
Yeah.
Because
And
sometimes
it
you
should.
just morning, you might not really notice it's moved much, but you might be on a dose of T3 that's moving a little bit in the daytime after a couple of hours. So at least you know the T3 is doing something,
Mhm.
and then to increase it.
Yeah.
So it can be helpful.
I do encourage they try to take it, but again, life is different in Canada than Ireland and England. Um, so speak just back to the reverse T3 because we've mentioned it a few times, but I know a lot of people won't know what reverse T3 is. So if you could, what is reverse T3 and how does it happen that someone can take T4 or T3 and create reverse T3?
Okay. Well, T4 um, um, is basically a molecule that's got four iodine atoms, and it means that it's not really an active hormone, a thyroid hormone. It doesn't bind to the receptors on the cell nucleus. It's pretty much inactive, even though it's the only thing that doctors tend to measure along with TSH. But it's really pretty much an inactive hormone. It's there to be converted to free T3. And T3 is a molecule that's only got three iodine atoms, and they're arranged in a certain way. Reverse T3 is exactly the same number of atoms, but the iodine atoms are in different places within the molecule. They're rearranged differently. And it is inactive. It doesn't connect to the nucleothyroid receptors, and it's there as a means of getting rid of excess T4 from the body. So it's pretty much an inactive hormone. So T3 is different. T3 does bind to the nuclear thyroid receptors. It's where the thyroid hormone actually works. It's inside the cell nucleus. So T3 is there. T3 is there to be the active hormone. Reverse T3 is there because the body's trying to clear excess T4. Now the body clears excess T4 when it sees that it's got too much T4, or when it sees it's got too much T3, and often it's using TSH as a tool for that inside the cells. And if just TSH comes down, you tend to get more reverse T3 from your T4 and less free T3 from your T4. And that's kind of basically how it works. And so reverse T3, it's not an active hormone. It doesn't do very much. It's there to clear things, but by measuring it, you can actually tell if it's high, you can tell that the body's desperately trying to clear this T4 out, and the body it's not making T4 into free T3. So you know something's wrong. It's an indication that the balance you've got between your T4 and your T3 hormone is not the right balance, or you've got too much T4. So it's a useful measure,
Mhm.
although it doesn't do very much itself. In
Yeah.
fact, in this country, endocrinologists have no interest in reverse T3. They
Yeah.
say it's an inactive metabolite, which is what you always get from them. And it is, except it tells you that the body's not working right if it's high and that the thyroid treatment isn't right.
So it can be an indicator that the T4 is too high and your T3 is too low. But also, if you have reverse T3 attached to the receptors, if you
Yeah.
do have any free floating active T3, they can't attach because that space is already taken.
No, it doesn't work like that. Reverse T3 can't attach to the receptors. It's not possible. It doesn't do that. And the way it actually inhibits free T3, and it does inhibit it, but
Mhm.
it's not the reverse T3 that inhibits it. There's a lot of stuff on the internet about reverse T3 that
Yeah.
isn't right. And basically, what inhibits the T3 is if the enzyme that makes the reverse T3, the
Mhm.
D3 dehydrogenase enzyme, if that gets super high, then it sits there. If the cell nucleus is there, the D3 enzymes sit there, and the T3 can't get to the cell nucleus. So it's the enzyme that's making the reverse T3 that's doing it.
Mhm.
But the reverse T3 is a harmless little beast. It's just useful to measure how high it is because it tells you that you've basically got your balance of T4 and T3 wrong.
Right. Thank you, because I clearly misunderstood that. Thank you for correcting me, because you're right. And there's a lot of thyroid practitioners who do say that reverse attaches to the receptors, and that's how the active can't.
All over the internet. It's all over the forums. Loads of people believe that reverse T3 connects to the receptors, and it just simply cannot do that. It
Thank you
doesn't.
for that. Yeah, because I would have been delusional had you not corrected me.
If you know it's a problem, you know high
Yeah.
reverse is a problem. So you can treat people really well. That's all you need to know. I'm just, you know,
No, it's important. Well, it's important for me as a practitioner. Well, I heard you, while we're on this topic of conversion, I've heard you mention before the aspect of cortisol in conversion, and that in some cases where it's too high, it's a problem, but also if it's too low, it's also a problem. Can you speak on that a bit?
yeah. Very, very super high cortisol can inhibit T3 action within the cells. Um, and also it causes a bunch of symptoms as well, which is not very nice. So high cortisol's bad news. Low cortisol's probably worse news because this T3, and this is cortisol, they're best buddies, they're partners. And inside the cells, both in the mitochondria and in the cell nucleus, they work together. If your T3 is low, your cortisol doesn't do its job properly. If your cortisol's low, T3, doesn't matter how much T3 you take, it won't work well. It just won't work well. You absolutely have to have both at the right level, especially if cortisol's low. Yeah,
And that comes back to T thyroid gland and the adrenal glands. They work synergistically, even though we're told so often that cortisol is the enemy, it needs to be in balance, just like everything else.
absolutely. Yeah, we don't want low cortisol, I can tell you. That's what kept me bedridden for several years. I had low cortisol. I didn't fail a test for Addison's disease, but because when they did a when I my baseline cortisol was really low all day long. It was super low. But when they test for Addison's disease, they measure that, and then they give you an injection of ACTH from the pituitary effectively, and they watch the response. So my cortisol levels leapt up after that. They were superb. So I didn't have Addison's disease, so my adrenal glands were fine. They just weren't making anything in the daytime because they weren't getting the signal from the pituitary gland. So in terms of synergistically working together, it's really the pituitary, the thyroid gland, and the adrenals all working together. Because if one of them's not right, the whole thing's not going to work well.
What do you
So
think
yeah.
got you to that point? Do you think it was burnout? Did they give you an adrenal dysfunction diagnosis?
No, they didn't. They said, "Oh, you passed the test for Addison's. Go away." Even though my baseline cortisol was awful, I
Yeah.
was passing out every day, blacking out with low blood pressure. I'd lost a third of my body weight. So I basically, it looked like I had an eating disorder. I had bones sticking out everywhere.
Yeah.
I couldn't function. I had to go up the stairs on my hands and knees. But as far as they were concerned, the endocrinologist who saw me, you just passed the test for Addison's disease, snap test, your cortisol comes up, you're fine, bye. And they sent me away. So that was all a bit disappointing because I thought we're bound to get a good result here, but no, they weren't interested. And what brought me to that point, I think being on the wrong thyroid treatment for too long. I'd been on T4 medication. I didn't have low cortisol to start with, I'm pretty sure of it.
Yeah.
And when I first went on T4 medication, I didn't feel as bad. But over the years, I'd been on T4 for so long that I had such low F3 T3 that basically something happened that made my hypothalamic pituitary axis change. And the pituitary didn't, even when I went on T3 in the daytime, it didn't start making enough ACTH to drive the adrenal glands. My cortisol never didn't even come up on daytime T3. It stayed low.
It's shocking. It's just like it's shocking that they have the audacity to say, no, it's not this. See you later. Bye.
Oh, that's right, yeah. And even when I basically corrected the cortisol by taking a nighttime dose of T3, even then, when I went back to see the same endocrinologist, I said, look, I'm fine now. Look at me. I'm fine. I've got my symptoms fixed. I'm dosing T3 like this. He said to me, oh, you shouldn't be on T3, you should be on T4.
Mhm.
Shouldn't be on that. You shouldn't be on it at all. I don't know. I'm going to write to your doctor. I don't think you should be on it. There's no need for it. I said, but on the T4 medication, I was really ill. On this, I feel fine. He said, well, something must have changed. It's nothing to do with the thyroid hormone. He was completely adamant that the fact that I was sitting in front of him well was nothing
It
to
was
do with
something
the,
else.
it
Yeah.
was something else.
I know. And like you mentioned this earlier that it doesn't bother you as much anymore because you're used to it. But to me, I have to stop and breathe. I just can't
Oh,
even
I,
like,
I, I got rid of that. I got a lot of my anger out in the books, to be honest. That's gone a long time ago. I get cross on behalf of the patients I work with. But I don't feel anything other than disappointment that the medical profession is where it's at now. And I think it's a real shame because this condition is not that hard to fix. It isn't hard. It's not. I'd rather try and fix this than, if someone presented with me with a cancer patient or a person with severe heart disease, I'd have no clue what to do. I
yeah.
couldn't do it. This is a really simple condition. You do the right tests, you understand the patient, and you look at your options, you make some changes, and you fix it. It's not that difficult.
Mhm. You had mentioned in one of your videos that I sent to you this morning, which I don't think we'll get into in depth now, but I will reshare with my group all these different categories of where a patient can fall with their treatment. I recommend everybody checks that out. I'm going to share it. Let's not get into it now. Um, it was a great video, like an 11 minutes long. Like I mentioned in the comments, straight to the point. That's what people want, just straight to the point. But I had a few more questions. One that actually was on my mind was, what do you think about someone who's using T3 but with a glandular or even desiccated thyroid? Like, do you have an issue with those combinations?
Oh, no. I mean, some people think some people probably because the first book I came out with was Recovering with T3, because that's what I'd used to get well. My GP had said, why don't you write something about it? So I did. And and you wouldn't get that from a GP these days either. But
Yeah.
um, so, but I've never had an issue with using T4 medication. If it works for someone, that's fantastic because it's the simplest way to take it. And I work with people where they're on NDT mostly, but they need a bit more free T3. So we add a bit of T3 in. NDT, T3 combinations, T4, T3 combinations, a gland, it's fine. It's all good. Whatever works, whatever gets the person to the right level of T4 and T3 for them and their symptoms gone.
Yeah.
That's what we're after. I don't mind what we use.
Yeah, exactly.
Oh,
And
oh,
I
go
was
on.
going to say the reason I ask is because there is a product I can access here in the store easily, and it's glandular.
Hmm.
So if I have an inkling that there is a thyroid issue, I'll start them on the glandular first. And a lot of the
Hmm.
time, we do see an increase in body temperature in a few days. So that's great. I'm happy with that. But sometimes then we'll also need the T3, and that's where we see that magic start to happen. And I have clients on desiccated thyroid, and they keep increasing their dose, but they're still freezing going around. They're still constipated. There's only so much you can keep increasing because, like you mentioned, you're also increasing the T4 there. You're not just increasing the T3.
Yeah, yeah, yeah. I agree. But yeah, and the people that come to see me, the people that come to see you might have a thyroid problem, right? People that come to see me are people that have been through several doctors, endocrinologists. I'm the end of the line guy
Yeah.
where they're so desperate they've come to talk to Paul. Okay. So I don't get the people that I'm going to start you on thyroid treatment. I don't get those. I get the people that have been on thyroid treatment for 3 years, 5 years, 10, 30 years in some cases, and they've eventually got fed up of it and it's not working. So I usually am not in a on a starting dose. I'm usually trying to undo something that they're already on and change it.
Yeah.
So completely fine. It's a good approach. It
Yeah.
often works.
Yeah, I'm usually getting people who feel rubbish. They've tried a lot of stuff, but I'm trying to nip it in the bud before it gets worse. So I'm looking at the symptoms and then saying, okay, I think before you end up having to go to Paul, let's see what we can do.
Yeah, quite.
One last question I had for you. I mean, we could talk for ages, but time is of the essence here. I wanted to ask, have you got much experience with utilizing progesterone for thyroid? Because progesterone is pro-thyroid, pro-metabolic. A mutual friend of ours, Keith, he uses progesterone a lot. I do too with my clients, but I just wanted to hear if you have much experience with it.
Well, I tend to use it with postmenopausal women with progesterone and estrogen to get the right balance. But I tend not to use it routinely for thyroid treatment. Do you use it with just women, or are we talking about men and women?
You can, I'll use it with men, women, kids. I have clients who use it on their dogs, like everyone, because progesterone really is our safest hormone. But sometimes, because of that battle of trying to get thyroid treatment, sometimes it's easier to just start with the progesterone and see if that will make a difference at all. Because again, I mentioned life is different here than it is in Ireland and England. I know we all have stress, but it's a lot more high wired over here. So I see a
Right.
lot of adrenaline dominance, a lot of sleep issues, a lot of anxiety. So sometimes that will be an indicator that I'm going to start with progesterone because it's the easiest thing to do. And also, I know that if they're having all these symptoms, they're most likely is low thyroid. So I'll start with the progesterone and see how we feel there before anything else.
You'll have to send me some information on that because that's not something I've really considered doing. So
Yeah.
that's new to me to use it in that way. So if
It,
you've got any,
it,
send it off later online.
I will. I'll send you whatever I have, but it is a case of, like you mentioned, whatever we can do to get the patient feeling better.
Yep.
That's where the aspirin comes in. Aspirin being pro-thyroid and pro-metabolic as well. Here you can walk into like our version of Boots and get a bottle of aspirin for $8. That's quite affordable for people. That's
Yeah.
doable. If I can do that and then start to see the core temperature increase, which I do a lot, like aspirin is really powerful for increasing core temperature, but that's doable. So it's whatever works, I'll try to use with them.
Great.
But
Really
again,
good.
like we mentioned, I'm in the I'm not like you at the end stage of trying everything. I'm trying to nip it in the bud in the beginning. I'm looking at these symptoms before they get worse.
Yeah, yeah, yeah. I definitely don't get that.
Which is important though, because we need to have different levels of practitioners, which like is where yourself and Keith come in. If I can't get an answer, then I'm going to potentially reach out to you guys and say, hey, do you have experience with this? We need different experience levels in all our practitioners.
Well, I'm sure you're gonna get to that stage. If you're doing what you're doing now, you'll be past us in very shortly by the sound of it.
I don't know, it seems very overwhelming sometimes. And I'm like, am I even up to this task? It's just like me against the world almost.
I'm sure you.
Paul, this has been great. Thank you for your time. The time difference I know is a bit of a challenge, but we made it work.
You did. Yep.
Um, so Paul, as mentioned, you have all your books. And yes, to everyone listening, you can get the books here in Canada on Amazon. Do you ship internationally from your website?
No, I don't. I'm relying on online booksellers and, obviously real live booksellers with shelves as well.
Yeah,
So yeah,
but that's okay because that's a common challenge whenever we're looking at Europe and Canada. There's always a challenge there. So we can get them on Amazon. Your website, what's that called so we can direct people?
okay. https://paulrobinsonthyroid.com.
Yeah, I'm going to share that in the notes and that video that I mentioned as well on those different categories. Is there anything you'd like to leave the audience with in regards to like where there's a will, there's a way, I suppose?
I think the biggest takeaway really that people need to have is don't don't just accept what you're being told by your doctor. Do your own research, take responsibility for your health, and do what it takes to get well. And if that means pushing your doctor a bit or finding a different doctor or doing whatever you need to do it. Because if you leave your health in a situation where it's not ideal, then other things can go wrong. And it's not worth doing that. Life's too short.
Yeah, it is. And
Yeah.
thank you for that. It is on each of us to take responsibility for our health. We've one life, and hopefully, most of us want to live it as best we can. I'm sorry to hear about all your struggles. It's just so frustrating and awful. But as we say, like a lot of practitioners, our mess becomes our message. So, what we've gone through, now we can help other people with, dare I say, the shite that we've been through.
Yeah, that's a good one. I've never heard that before, but it's very true.
There you go, you can have it. Okay, Paul, thanks for your time and hopefully chat to you again soon.
Yeah,
Bye.
you take care. Bye.